A 73-year-old patient presents from podiatry clinic for worsening left foot pain in the context of a non-healing diabetic foot wound. No pus can be expressed from the wound, and there is no evidence of wet, dry gangrene. You decide to order a TcPO2, and it results as 28 millimeters of mercury. Who should you consult next? Infectious disease, vascular surgery, general surgery, or endocrinology? I'll give you 10 seconds to think about the answer. And the answer is vascular surgery. So we're going to go over what the heck transcutaneous oximetry is. So this is something that we do at the VA, and it looks like this. Sorry about the lack of trigger warning about the foot ulcers. I'm sure you all have seen something gnarlier working at this institution. But basically what's happened is electrodes are actually placed with sensors on a patient's limbs, and they actually run electricity through them to induce some vasodilation, and they see what. So it's kind of like a stress. So think of your regadenoson causing vasodilation. It's kind of like that. So the question becomes, how do I interpret the result? So it results as a partial pressure of oxygen, and units are in millimeters of mercury. And the reference range actually depends on the site. So the foot, the chest wall, every limb has a different cutoff. For all sites, however, if it is less than 40, it indicates wound hypoxia. And if it is less than 20, it indicates critical limb ischemia. So clinically, I think this can be helpful if you cannot tell if there's critical limb ischemia and you do this test and then you go, uh-oh, I'm in trouble. You have to ask yourself, what can falsely lower the result? So if you're sitting versus supine, that affects the blood flow to the area, and that can actually affect the partial pressure of oxygen. Caffeine consumption can affect this. So very similar to how it interacts with regadenoson, turns out there's an issue here. Smoking can as well, because that causes vasoconstriction that may be related to the act of smoking and not so much in their steady state. Temperature of the room can obviously affect things. If it's cold, you may vasoconstrict. And then things like edema, acute infection, and scar tissue will actually interfere with the result here. So I think this result can actually be really helpful because it helps you decide if the patient's going to benefit from a combination of any of the following: vascular surgery, IR, and then hyperbaric oxygen. So very often we're seeing patients who come in with some sort of foot wound, diabetic foot wound, there's a component of ischemia, and you're consulting the trio of ID, vascular surgery, and then IR. And this can actually be rather helpful in discerning what's going on. So if the result is less than 40, you can consider hyperbaric oxygen therapy. And a change in the TcPO2 during hyperbaric oxygen therapy actually predicts success of hyperbaric oxygen, so you should keep doing it. And theoretically, that can fix the issue. So in summary, the transcutaneous oximetry is something where you have electrodes that are placed around a wound and heated. That then causes vasodilation, and you get a partial pressure of oxygen that gets measured. It assesses the microcirculation of non-healing wounds. It can help you determine if a patient can benefit from vascular surgery or IR or hyperbaric O2 therapy. The reference range will depend on the site of testing, the foot, the chest wall, the arms, etc. But for all sites, if it is less than 40, it indicates wound hypoxia, which should trigger probably some of the consults above. And if less than 20, critical limb ischemia should prompt very urgent consultation of the folks above. And that's all I've got.